Okay, I suppose that everyone has watched the video on mental state examination. Did you?
Yeah.
Okay.
Yes.
Right. So this is supposed to be a question and answer session about mental state examination or anything which is not clear in the video. So this is the time for you to come forward and ask questions or discuss things. So I'll just let it be an open session for you to come forward and ask questions if you want. You know, we are so used to keeping silent in clinic. And I can do this for half an hour or so.
Doctor,
Yeah.
I want to ask about the effect, the death effect. Not quite sure what.
Come again, sorry.
One of the things that we need to see to ask for the patient for the mental state examination is the effect, right? And one of it is the death. Can you explain more about this? It can be normal or abnormal.
So you're asking about death, about depth
Yes, that.
of effect. So in effect, when you assess someone's effect, you don't ask question. So effect is basically based on observation, what you observe on the patient, right? So effect is patient's facial expression, the posture, the body movement related to their emotions, the mood. Okay. So one of the component of effect is whether or not the effect is congruent or incongruent to the thought or incongruent to the mood. As I said, maybe if the person is sad and suddenly he laugh or she laugh, so that is a bit inappropriate. If it is more persistent, kan? So maybe it's incongruent to the thought. Patient is thinking about something yang worrying, but the effect is not how it's supposed to be. Yeah, so that is incongruent. So that is the first component of effect. Inappropriate, incongruent. Lagi satu, we talk about labile, whether it's labile or not. So labile tu selalunya we limit the use of labile when the effect changes from one extreme to the other extreme. Like happiness, you know, joy, elation, to crying, sadness, and being suicidal. So the effect change. Okay, so that is labile. When we talk about depth, broad, I mean the range. Range is about the spectrum of emotions that can be sensed through what you see. Okay, so from anxiety, from normal facial expression to sadness. So if you can see those range of effect, then you can see it's a broad range. If let's say the facial expression is like a one kind of presentation, so probably it's restricted to certain effect. Okay, and blunted is something else yang macam where there is no facial expression at all. Okay, so the depth is something else. Okay, the depth, when you talk about depth, when someone talk about being sad, whether the effect the set effect tu, it's superficial or it's something that you can feel it as maybe intense. So depth and intense ni something yang macam interchangeable. Okay. So the depth and intensity of that effect, intensity of that, the facial expression that patient show to you, whether it's superficial, whether it's deep. Okay, you can see sometimes when patient talk about something sad, patient start crying, the face start to become red, and you can sense that the patient is in deep emotions. So that's the meaning of depth. Okay, so there is no question to ask that. It's based on your observation and based on what the patients share with you. Okay.
Okay, doctor. I just want to ask you a question. How can we confirm that our examination is reliable? It means that the patient is not faking it, just like in the pseudo hallucination, that patient make it like a real thing. Yeah. Get it?
Okay, thank you. I think it's a good question on how we can validate or how we can verify whatever the patient is experiencing or the patient is showing. There's two things here. The first one, sometimes when when the patient shares something with you, so you experience something in you. Okay, patient is saying something about the loss. Patient is showing certain affect on his or her face, and you have some idea in your mind what is the patient going through. Okay, so that idea in your mind, your theory about the patient may be right or may be wrong. For instance, someone said that, or maybe someone passed, someone's mother passed away, and then she is, looking toward that side and then crying. So normally you would think that the person is sad. Normally the person is sad. You think the person is sad. So you think the person is sad, but can the person actually experiencing something else? The patient is crying. Can the patient experience something else?
Yes.
What is it? Other than sadness, what could it be?
For crying out.
Happiness.
Happiness.
Okay, it can be happiness. Okay, happy and you cry. Okay, or you feel angry. The person might be angry because the mother left her suddenly, like what she did in the past. Contohnya, So it always good to double confirm with your patient. I can see that you start crying when you talk about this. You must be you must be feeling very sad about the loss. Am I right? So that is double confirming with your patient. What you think, what you feel, you verbal it out, verbalize it, and then confirm with your patient whether what you think or believe is right or not. Okay, so that is one way. The other thing is what you asked just now, whether patient to the fake ataupun feign the symptom or not. When you talk about pseudo hallucination, it's not about feigning symptoms. It's not about making up sign and symptoms. Pseudo hallucination is patient really experience it, okay, but it doesn't fulfill the criteria of true hallucination. Okay, true hallucination, we say that the patient experience the hallucination in the external objective space. Apa benda external objective space ni? Basically, patient experience it macam benda tu berada di luar, as if the things is really exist outside. So external objective space tu maksudnya this objective space is not inside, it's something outside. And the patient can really hear it or see it or smell it or taste it but nobody else can do the same, or nobody else can experience the same. The stimulus is not there, but the patient experience it clearly in fully consciousness, and it cannot be controlled. So in that sense, it's true hallucination. In pseudo hallucination, the person can will it, meaning I can call the voice. I call the voice and then I hear the voice. Or I can say to the voice, go away, and the voice will go away. Or the voice will only come only when I feel extremely sad. When I feel very, very sad, the voice starts coming, saying, kill yourself. And then 1 hour later, when I'm okay, I've taken the medication, or some friend visited me, the voice is no more. Or maybe the hallucination occur when I was on the verge of falling asleep. So that is pseudo hallucination. It's not about feeling symptoms. It's a true experience, but it is not true hallucination. Okay, so differentiate between that. Kalau kita kata the patient feign symptoms ataupun fake the symptoms, that is probably factitious ataupun macam malingering. Okay, and that is totally different discussion. Any other question?
Thank you, Doctor.
Okay.
One more about the speed of the speech. How does this help in the diagnosing the patient? It means that the patient speak fast or patient speak slow.
Come again, sorry.
How the amount and the rate of speech help in the diagnosis of the patient?
How does the amount of speech,
The rate of speech. I mean the it's stated in the slide that the flow, stream of flow refers to amount or rate of speech include the pressure and speech, and probability of speech thought luck found in mood disorder in schizophrenia. So this means that if the patient speak fast, we can say that the patient has schizo or something like that. Or
okay, give me 5 minutes. Give me 1 or 2 minutes. Sekejap nak pasang benda lah ni. So how does the speech help in the diagnosis? So basically, MSE, you can use MSE as an additional evidence for you to make or for you to commit a diagnosis. Okay,
MSE.
sometimes mental state examination lah.
Oh, MSE. Okay, okay, I see. Sorry.
Right. So sometimes the thing is not mentioned in DSM, your diagnostic statistical manual. Bila kita nak diagnose, when you want to diagnose someone with a psychiatric diagnosis, you have to refer to DSM-5. So DSM-5 serves as a manual. The criteria are all there for you to diagnose someone with a psychiatric diagnosis. Contohnya, you want to diagnose someone with schizophrenia, you have to fulfill the criteria of 1 is hallucination, 2 delusion, 3 negative symptoms, 4 disorganized speech, disorganized behavior. So out of 2 of these symptoms, kalau fulfill, plus with other additional criteria, you can commit the diagnosis of schizophrenia. But then, there are other things that are not mentioned in DSM which can be used as evidence to support your diagnosis. Contohnya, it is known that patients with schizophrenia, they have incongruent affect. Regardless of what topic they discuss, whether the following emotions are sad or happy, their faces remain blunted. Okay, their faces remain blunted, or sometimes incongruent, or go opposite of the following emotion. Okay, so that is suggestive of schizophrenia, but not diagnostic of schizophrenia, because there is no such thing as pathognomonic in psychiatry. Okay, there is no one symptoms or one signs or one cardinal features which is diagnostic of a particular psychiatric diagnosis. So the same goes with speech lah. So typically a patient who speaks fast, talkative, having flight of ideas, or sometimes become circumstantial in the speech. So these features are suggestive of a mood disorder like bipolar mood disorder, mania. But they can also exist in patient with schizophrenia or someone yang maybe ada OCPD personality traits. Sometimes patient with OCPD, obsessive compulsive personality traits, the one who is always perfectionist, want to do the best, very rigid and try to control things around her or him. So sometimes when they describe things, they tend to become details, to put in details in their speech. And usually kalau dia nak jawab satu soalan tu, dia akan pusing, cerita all this stuff which she thinks important and come back to the topic. So maybe in 15 nak jawab satu soalan tu, maybe 15-20 minutes baru dapat jawapan ni, right? And patients who are anxious, they tend to speak what?
Faster.
Kalau you anxious like exam, you buat macam you speak faster, right? So that's how speech vary according to emotions and mental state ataupun diagnosis tu. So the conclusion to your question tadi tu, yeah, certain criteria, certain features of speech can be suggestive for certain diagnosis, right? Like macam saya cakap tadi, when the speech become the rate increase, the volume increased, and the patient is having pressure of speech in which you cannot stop. This afternoon I'm gonna give you some sample video. You're gonna appreciate how does a patient with bipolar or some other diagnosis present with this. So where did I stop? So yeah, so patient yang ada certain features in the speech can suggest of certain diagnosis lah. Okay. Did I answer your question?
Okay, thank you, Doctor.
Okay.
Assalamualaikum, Doktor.
Ram.
I would like to ask about the mental state examination. From my understanding, examination is something that we analyze, that we ourselves try to pick up something that from the patient, unlike symptoms the patient explain it. So normally in other postings, so we clock the history, then we do physical examination. So that's the clinical practice. So in psychiatry posting, how do we apply this? Do we, after we clock, do we do some examination? Because from my understanding, only the yang hujung-hujung dia macam where we do some examination, like we ask question to see whether cognitive function and so some specific question lah. But other than that, it merged in the history taking.
Okay.
So how do we apply in our clerking and examination, and how is it something that we must present as part of the HOPI or macam dia macam physical examination like mental state examination?
Right. Right. Okay. Thank you for your question. May I know siapa tanya soalan tu?
Daniel.
Daniel. Right. Okay. Thank you, Daniel. It's an important question. I was looking at the gambar-gambar ni tapi dia macam tak bergerak kan. Macam ada orang bercakap tapi mulut dia tak bergerak. So I tak tahu siapa yang tanya soalan. Right. So with regards to examination in psychiatry, what is the importance of examination? Where should you present it? When you should present it? This is really important question. I'm glad that you asked this. So basically, psychiatry diagnosis, all psychiatric diagnoses are diagnosis of exclusion. Okay. What do I mean by this? You want to diagnose someone with a psychiatric diagnosis, say depression or anxiety, you must first of all exclude other medical or surgical causes that which may contribute physiologically to the cause of it. Contohnya macam someone presented with recurrent palpitation, shortness of breath, tremors, pre-syncope plus fear of death during that time. Okay, and this has been occurring multiple times. So your task as medical students, as doctors, first of all, you have to see whether or not any medical condition can explain this presentation. Can it be hyperthyroidism? Can it be tachyarrhythmias? Can it be MI? Can it be side effect of salbutamol because of asthma? Can it be what else? Can it be because of hypovolemia or anemia? So you need to exclude this. So in the history and the HOPI, one part is to elaborate on the symptoms, the nature of the symptoms, palpitation tubular, the frequency, how long did it take for to go upsurge and then go to settle, cognitively what the patient thinks, emotionally what the patient feels, what are the associated symptoms that the patient had, like hypothyroidism. Hypothyroidism, symptoms apa yang tidak ada dalam panic? Contoh. So you must be able to pick up certain signs and symptoms yang ada dalam hyperthyroidism but are not present in panic. Contohnya macam increase in appetite but losing weight, heat intolerance, that kind of stuff, which are not present in panic. If those specific critical symptoms are present, then you should be thinking about organic cause lah. Maksudnya this could be thyroid, unlike panic. So examination or your thought tu about other causes and whatnot tu dah start since HOPI lagi. Okay, so you must be thinking of other causes dekat situ dah. Contohnya in schizophrenia, a patient presented with hearing voices 1 week prior to admission. So you are thinking about schizophrenia, but schizophrenia is the last one. Before you go to schizophrenia, you must exclude substance. So substance is so common nowadays, especially among youngsters. So you must exclude that, whether the patient had any history of substance. So let's say the patient ada ambil substance, ataupun the history, patient said, I used to take substance last time, but this time patient deny. You still doubt whether the patient takes substance. So you must be thinking about, okay, there are things that I want to examine on this patient. There are signs that I want to look for. Contohnya in, let's say the patient is taking amphetamine. Okay, amphetamine, which is a stimulant type substance, which is, you know, it can cause hallucination. So you might want to look for dental caries. You want to look for dryness over the dekat dalam nostril dia. You want to look for you know, skin changes around this area. You want to look for cachexia. You want to look for injection marks. You want to look for this and that. So there are many signs and symptoms which can help you to make a diagnosis. Okay, so so the process started since HOPI. You also do the systemic review in your HOPI, GI, CVS, endocrine. So you do that. Apart from psychiatry punya systemic review, walaupun patient tu present dengan psychosis, so you think the patient has schizophrenia, but you still have to go through other domains. Dalam psychiatry ni ada psychotic domain, ada mood punya domain, ada anxiety punya domain, kan? So anxiety domain, you're talking about anxiety disorder. Mood domain, you're talking about depression and bipolar. Psychosis, psychotic lah. So walaupun patient present with psychosis, but dekat bawah tu, you want to also exclude mood symptoms. You want to exclude anxiety symptoms. And then you exclude medical symptoms, all the systemic review. And then you go to physical examination. You know, once you have presented HOPI, you go to past medical history, past surgical history, family history, personal history, pre-morbid personality. And then you go to mental state examination. Sometimes we proceed with cognitive examination like MMSE, mini mental state examination. Then you go to physical examination just like normal, with particular importance to neurological examination. So neurology and psychiatry is something yang two fields that cannot be separated. We like to think psychiatry diagnosis as biological or neurological in nature, but there are things that cannot be explained neurologically. Okay, maksudnya ada psychological component yang beyond neurology sahaja. So this is something yang more complicated lah. Okay, so saya menjawab soalan atau tidak, Daniel?
Menjawab.
Menjawab kot. Kalau tak menjawab, bagi tahulah.
Mungkin sebab tak, dia kena practice dulu, perlu nampak.
Which
Jumpa
part that
patient.
you don't understand?
The ability to catch up the signs, Doctor. When we, is it like how we examine the mental state examination is during our interview when we talk with the patient, communicate and interact with the patients, and then we catch up the nuances like the gestures and then the non-verbal cue that the patient gave to us. Yeah.
Right. Okay. Now, okay, like in medical, you clerk the patient, and then the habis clerking, you start examine the patient, right? So in psychiatry, you can do it simultaneously. As you are clerking the patient, so you start to notice changes in the facial expression as patient talk, right? So that is something important that you want to include in your MSE. So it doesn't mean MSE, walaupun dalam susunan is after HOPI, after clerking, it doesn't mean you have to do MSE after that only. So it can start during clerking. And MSE, the presentation is just to summarize all these informations that you got during clerking And perhaps sometimes there are questions that you may not be able to answer to ask during clerking, but you ask during MSc. Contohnya, soalan about cognition. Okay, who am I? What is the date today? So you may not be asking that question in clerking, but you can ask that question that you have not asked during MSc part. Faham tak?
So you still have two part lah, the HPI and then
Yeah, you
things
can
that
say
they
it's two part. You can say it's two part, but most of the time it is done simultaneously. Okay. Yeah, so it's more of there is no physical examination in that sense that you have to do certain maneuver, but it's related to certain question that you say to the patient, and the answer that the patient give you would be included in MSc. MSc is a cross-sectional study of the patient's emotions and thought. Maksudnya sekarang, if the patient tells you, oh, last week I think about killing myself, so that you should not include in MSc, because MSc is about now. How do you feel now? How what are you thinking now? So dalam clerking tu, you ask about the patient seminggu punya psychosis punya history kan, and then we always come back to what about now? Do you still hear voices? If the patient say yes, then you take that part in MSc, in perceptual disturbance. The patient complain of hearing voices during interview. So that is MSc. Sekarang ni, mental state examination now. So it's not about yesterday, it's not about 2 days back, it's about now. Why is it important? It serves as a baseline. You see the patient today, maybe 1 hour or 3 hours later, patient change. And also, you want to see whether the patient responded to medication and treatment or not. Okay.
So it can be, the patient can be normal at the time of the MSc.
Yeah, the patient can be normal during the time of MSc, having no symptoms. And that's the limitation of MSc. Just like, you are seeing someone for 1 hour or maybe 10 minutes, and then you can say the patient, I think they need a certain condition. Kan? 10 minit apa sangat lah you can diagnose a person kan. So MSc pun macam tu lah. During this time, I may not be exhibiting the symptoms and sign, but sometimes later, the symptoms emerge. Just like you punya atrial fibrillation, okay? Yang jenis yang macam, what do you call that? Yang intermittently ada tu. What is the name for that? Ni baru habis year 3, 4 ni ha. What is the type of atrial fibrillation that comes and go? Is it paroxysmal?
Paroxysmal.
Okay, so paroxysmal AF. So sometimes ada situ, sometimes tak ada. If you were to, palpate dia punya pulse during the time which he doesn't have AF, you're gonna say the patient is completely normal. Kan? And then you auscultate, you tak dengar apa-apa because the patient doesn't have AF at that time. So psychiatric diagnosis sometimes macam tu juga. Yeah. Any question? Lagi?
Maybe not related to MSc. So how do we determine that the patient can be admitted to the hospital or not?
The two principles that you use in order to save someone by admitting her or him to hospital is whether or not the patient has, posed any harm to himself or pose any harm to other people. So those are the two principles: harming yourself and harming other people. So those are the two principles which you use to admit the patient to the ward. Harming to yourself means, killing yourself. But sometimes it's not about suicide sahaja. Let's say in the case of bipolar mania, the person is expending 1,000 a day because of the pathology that he has. I keep on spending money because of I feel happy. When you feel happy, you start shopping, Lazada, Shopee and whatnot, and then you use up all your credit card, the allowance that have been given to you. And that is a harm for you, isn't it? You start, pinjam along and whatnot. So it's a harm. So you want to prevent that, you admit the patient, or if you don't want to admit the patient, you start treatment with proper monitoring at home. So we have choices whether to admit or not to admit. If let's say the patient can be monitored, the support system is good, the family is strong enough to care for the patient at home, then we discharge the patient with medication. If let's say the family is not available, there's a lot of conflict at home, you may want to admit the patient in order to prevent further harm upon himself. So that is harm on himself. How about harm to others, like homicidal ideas or aggression and whatnot? Okay.
Okay, thank you, Doctor.
Welcome.
Doctor, I have one question. Under the subtopics of on the assessment of thought, one of the component was possession. Possession here maksud dia sama ke dengan rasuk ke, like tu literally? And I can't really understand the difference between thought insertion, thought broadcast, thought withdrawal dengan somatic positivity. Perlu ke faham? I mean, like, is it really important to know?
It is important if you are doing psychiatry posting, right? Or if you are experiencing those symptoms, it's important. Apa nama awak? Ibrahim?
Alia Ibrahim, sorry.
Right. Okay. So possession is not about it's not about that spiritual possession. Okay. But there is something similar in psychiatry. You see that kind of stuff also. Interesting bila you sebut macam tu. So possession, when you talk about possession, thought possession is about tadi itulah, thought insertion, thought withdrawal, thought broadcasting. Okay. So we think, we believe that we possess our thought. Betul tak? Do you guys possess your thoughts?
Does it mean like we control our mind kind of thing?
Come again?
Or is it like we own our mind? Does that mean by possessions? Ke tak dengar?
I dengar. Dia macam breaking. Cuba cakap sekali lagi.
Does possession of our mind means that we are in control or we own our mind?
Yeah. Okay. So that is the that is not the answer. Tapi we think, we believe. Normally, we control our mind. We can have some sort of control in ourselves. We can control what we want to think, what we want to eat afterwards, what we want to do, at what time we want to go to school, whether we want to fast today or want to break fast, we have that control, kan? We have that idea that we can control ourselves. When we talk about possession, the person experienced something, an external agency. External agency ni nama yang generic, okay? In our culture, they call it setan, they call it sihir, they call it sucker, and whatnot lah. Okay, there are many names of it for it. So how do they experience? They experience that something, you know, a thought is inserted into their mind. This thought is not mine, but it's something else. Someone or some power, an external agency inserted the thought into my mind. Okay. And then my thought is being withdrawn from my mind. So my mind become blank. I wanted to say something to you, but suddenly something withdraw my thought from my mind. Thought broadcasting. I'm thinking about something and suddenly it is being broadcast to everyone. So everyone knows what I'm thinking now. So it's a belief, 100% without any doubt. So it's delusion. Thought echo. As I'm thinking about, you know, giving a lecture like this, dan sebagainya. Okay. Yes, thank you. So that usually diorang cakap possession lah, right? Possession in which people lose the ability to control themselves. So that is one part. Psychopathology in contohnya schizophrenia, psychosis, they experience that kind of experience. But in reality, do we actually own our thought? That is another question that you have to ask yourself. Do we really own your thoughts? Do we actually have a full control of our thoughts and emotion? That is another spectrum of discussion. So what do you guys think? Hello?
Hello.
Hello.
Sorry, saya on call. So dapat telefon, right? Sorry. So my question just now, do we really own or possess our thought? Your own experience will tell you the answer.
I think we are.
You think you do? Good. So you will be responsible for every thought that you experience. Will you be accountable to those thoughts? Yeah, you don't like? Okay. So this is something, okay lah.
There's a
Sebab
paradox.
ramai yang tak menjawab. So go back and reflect on this. And later we discuss if you want whether or not you own your thoughts. Okay. Kalau you rasa you own your thoughts, what are the evidence that you own your thoughts or feelings? If you think that, you know, I don't own everything, what are the evidence? You know, you can give evidence from any perspective lah. From neuroscience punya perspective, from maybe religious perspective. Okay.
Tasawuf.
Yep. Okay. Any other question?
Doctor, I have question.
Yeah.
Okay. So kan sekarang most boleh jadi ramai of the patient self-diagnose. So during the assessment, how we can know that we're not being manipulated by them?
Okay. Talking about self-diagnose kan, why people self-diagnose themselves?
Munchasen.
Munchausen senang hati je. Okay lah, boleh lah. That's one of the reason. Tapi why do people self-diagnose themselves?
Maybe in my opinion that the self-diagnosis, they just want to rationalize what's going on with themselves. Like they feel this and they feel that, and then they read just to reassure themselves, or maybe just, you know, because when we are not conscious about what, or we are not aware with what's going on with ourselves, we feel discomfort with our own self lah. Maksudnya dia ada problem dengan diri sendiri.
Okay, so that is a good explanation that we need some kind of explanation to explain things that happen to us kan. So how do we get the answer is by attributing the things that we experience to a diagnosis. Because you know, sometimes having a diagnosis is already macam relieving to certain people. Oh, at last I tahu juga kenapa my mood is like this. Or at last I know why I feel anxious meeting people. So because of this diagnosis. So from, you know, saying this is my problem, this is actually the diagnosis problem. This is something else in me, something that can be treated. So having a diagnosis can help certain people, and some people don't like diagnosis. Okay, so that's given. That's depend on people personality. So yes, people attributed what they experience to a certain cause. So there are many reasons why people seek treatment, get diagnosed, or even self-diagnose themselves lah. But we have to bear in mind that we are the worst evaluator of ourselves. Okay, we are the worst evaluator of ourselves. We think that we are rational being, but studies have shown that men are not rational, especially when it comes to spending. Right? So you can read books written by I tak ingat apa, the psychologist. At the same time, he's doing study in economy. Thinking Fast, Thinking Slow. Have you heard that book?
Daniel Kahneman.
Yeah. So Daniel. So that is an important book to show that, you know, sometimes you don't actually think rationally. Okay. That you can start questioning the expert who has done PhD in that area. Why? Partly because of arrogance, pride.
Dunning-Kruger.
Sorry?
Dunning-Kruger effect.
Yes, Dunning-Kruger effect. So partly because of arrogance and pride, and partly because we don't actually assess ourselves correctly. Okay. So, and the worst among us adalah mereka yang perform worse in the task given. So those who perform worse, they tend to evaluate themselves better. Faham tak? I'm not good in this study, but I give my marks higher. As compared to those who are really good in that task, they tend to lower themselves, lower their expectation and lower their evaluation of themselves. So this is something to do with, with being humble, humility, being pride. Really, because if you listen carefully to the our Muslim scholars and whatnot, trying to handle these vices kan, sifat-sifat mazmumah seperti pride, arrogant, ujub, takabur and whatnot, it's really, if you have these traits, it hinder you from getting the truth. You elevate yourself to this level, and then when you listen from someone who is you think lower than you, so if the person tell you something truth, you tend to deny. So that's something yang people have been agreeing since before. So yeah, kita dah deviated from the topic of self-diagnose. So self-diagnose, yeah, it cannot be accurate. I cannot diagnose myself with OCD, even though I think I have OCD. So I need to be, I need to come forward and see someone yang neutral, so that everything can be assessed objectively lah. So in many times, patient come to me saying that I might be having OCPD, or I'm having this condition, but through experience, and then there are certain objective scale questionnaire that you used. So this tool may help you to come with a proper one lah. Sama ada patient ni ada diagnosis or don't have any diagnosis. Okay, and having psychiatric diagnosis nowadays may give you certain privileges. Okay, and I'm not saying that all patients like that. No, many of them really need the help, but some minority, abuse the system, just like in medical and surgery. Okay. Okay. Any other question? If there is no question, where is Aina? Aina mana Aina?
Ya, Doktor.
Aina. So regarding PPV punya simulation exercise tu, I have informed Prof. Ramli as the coordinator, as well as Dr. Nora as the HOD. So HOD seems not too aware about it, and she will bring the issue to today's punya meeting lah. But for this afternoon punya session, I don't mind if you guys want to go. Then we replace afternoon session to sometime later. but the decision on that, I think we have to wait for Dr. Nora punya meeting petang ni lah. I understood that it was decided earlier on before you know that you have this posting. But we have to balance lah between class, commitment and your volunteerism, which is good.
Okay, Doktor.
Boleh Aina?
Boleh,
Right. So petang ni punya session, since I cannot stop you from going because it's already decided and Dr. Nora is only going for the meeting afternoon. So shall we replace class petang ni to sometime later? What do you guys think?
Boleh je doktor.
Ketua kelas siapa?
Hey, Doktor.
Okay, Alif.
Cik Alif.
Ya,
CMA eh?
ya Doktor.
Okay. Abang Haris, sit down. So this is the challenges, teaching at home. You have 2 kids and then they are all running and that. Five videos. Abang Haris, I'll be sharing 5 videos about mental state examination. So basically we have 5 simulated patients: mania, psychosis, depression, anxiety, and substance. How many students we have here?
146.
Oh, besarnya. Right, 146 kalau nak divide by 5, 20. Do you guys have your own group?
Yes, Doktor. According to supervisor.
Berapa ramai? 6 lah.
7 supervisor.
7 supervisor, 140 is around 20 lah. Satu group 20, is it?
Yes, Doktor.
Okay. So maybe I can, split yourself into 7 groups. Each group just watch 1 video. Everyone in that group watch this video and extract points for mental state examination. Maksudnya general appearance dia apa, speech apa, mood apa, affect apa, thoughts apa. So dissect what you see in that video, put it in point form, in presentation form, and later when we meet, you can present your finding. Is that okay?
Okay, Doktor.
Okay. Right. Any last question? No? No?
Doctor, I have a question.
Yeah. For you. Siapa nama?
Ni Akmal. Mine was taken out, and so actually the difference.
That is as if, seolah-olah. You feel as if you are flying. You become detached from your body. It's out of body experience. You rasa seolah-olah terkeluar daripada jasad. Ya, rasa seolah-olah, ya, bukan percaya. Sebab percaya itu delusion. So that kind of experience that happen during intense emotion ataupun extreme emotion like sadness ataupun panic. So kita panggil this depersonalization. In derealization, you experience the environment as if you are in a dream. this is a dream. This seems like a dream. Okay, macam dalam mimpi. You know, sometimes people say that, you know, saya lalu dekat satu kawasan tu rasa macam seolah-olah dekat dunia bunian. Right? So that is the realization. It can be hallucination, depending on what the patient tells you. Hope that answer your question. Okay. Sebenarnya yang belajar daripada rumah ni stres ke?
Susah nak
Sekarang
fokus.
ni dekat susah nak fokus.
Kalau
Tapi
tak
dari
ada,
segi komitmen, dari segi assignment banyak ke?
kalau tak ada assignment tak stres.
Tak ada assignment, tak stres. So bagi satu video untuk 20 orang tu stres lah.
Oh, tu tak stress lah, satu je. Boleh.
Right. Sekarang ni tengah hot dekat Twitter Jaya kan? Right? Because of 2 students died. Okay, you know why people, what could be the cause of that, kan? Okay, don't oversimplify things. Yes, we agree that, you know, working from home, you know, studying, you know, distant learning online here are really difficult for every one of us. Okay. So if you know, your feedbacks are valuable, so inform us, please tell us if you know, have a better way on how we can accommodate your needs. Okay. Okay, everyone. Okay. Okay. Thank you very much. See you later.
Sir.
Bye.
Thank you,
Thank you,
Doctor.
Thank you, Doctor.
Thank you, Doctor.